Welcome everyone to today's or this month's ICARE Genetics Case Conference. My name is Brenda Zuniga and I'll be your host with Dr. Powell.
I wanted to start with a case after which we're going to introduce our guest speaker for today, Dr. Will Foulkes. So this is a case that was seen by my colleague, Meredith Gerhardt, who's a genetic counselor at Vanderbilt. And the reason for referral was this patient had a small cell ovarian cancer, 22-year-old who was diagnosed with this ovarian fallopian tube cancer. It was a small cell carcinoma of the ovary, hypercalcemic type, also referred to as SCCOHT, I guess, predominantly large cell variant, and it was diagnosed at stage 3A. The treatment was unilateral salpingo-oophorectomy, as well as 4 cycles of chemo. And you can see here the pedigree. Again, we're not seeing anything in terms of cancers in either of the parents. They're both of Guatemalan descent. So there was genetic testing done, 23 gene panel, and the results showed a SMARCA4 pathogenic variant. So looking at the assessment, we know that SMARCA4 pathogenic variants are associated with small cell carcinoma of the ovary, hypercalcemic type, but the lifetime risks are not fully characterized. So we're going to learn a lot more about this from Dr. Foulkes today. In terms of the treatment assessment, there were enlarged lymph nodes anterior to the transverse duodenum, which had previously measured, similar sizes, both prior to and following the treatment. There were no new enlarged lymph nodes within the abdomen or pelvis, no suspicious pulmonary nodules, no evidence of metastatic disease to solid organs. And the end assessment was she's at very high risk for recurrence, and the recommendation was continued surveillance with imaging. So preventive oophorectomy after puberty could be justified, was the end assessment. The recommendation for completion of oophorectomy by the gynecologic oncologist was declined by the patient pending fertility preservation. And again, family considerations, we know that there is an inherited mutation, so implications to family members. So I just wanted to add in a few additional papers, some of which Dr. Foulkes may talk about during his talk. But there was a paper that came out back in 2013 that makes us think about additional treatment considerations. So in patients that had low mutation burden cancer, and this type of small cell ovarian cancer, 8 out of 10 demonstrated PD-L1 expression with strong associated T cell infiltration in both tumor and stromal cells. And the findings suggest that immunogenic microenvironment resembles the landscape of tumors that respond well to PD-1, PD-L1 blockade. So again, suggestive studies. This is, keep in mind, these are low mutation burden cancers. So it's a little bit of a different angle. Usually we think of high mutation burden cancers as responding to immunotherapies. And then I wanted to highlight one article on which Dr. Foulkes was a co-author. So in addition to considering immune checkpoint inhibitors, Dr. Foulkes also co-published work focused on palbociclib and this type of small cell ovarian cancer. So with that, I wanted to introduce our eminent speaker, Dr. Foulkes, who is a senior scientist professor at McGill University. I've had the pleasure of knowing Will for, since the late 1990s when I did my fellowship back in Canada. Now, Will is a physician scientist at McGill affiliated hospitals since 1996, and he leads 2 cancer genetics research laboratories. He's also a fellow of the Canadian Academy of Health Science, the Royal Society of Canada, and the Royal College of Physicians in London. He's known for many different things focused on inherited cancer susceptibility and is one of the world leaders in this area. He is known for the discovery of founder mutations, including the MSH2 missense mutation in Ashkenazi Jewish individuals, as well as PALB2 and RAD51D mutations in French Canadians. He's also identified biallelic variants in SMARCA4 as the cause of small cell carcinoma of the ovary, and defined the phenotypes linked to DICER1. So again, we are really excited to hear what Will has to tell us about SMARCA4. So I'll hand it over to him. Thank you for being our guest expert.
Great, thank you. God, who wrote these slides? Bloody awful. Oh, it was me. Okay, yeah. Okay, so I'm going to talk a bit about SMARCA4. I call it SCOHT. It probably should be SCOHT, but there's no really good name. I mean, small cell cancer theory is interesting. It's like the Holy Roman Empire. You know, it's neither Holy Roman nor an empire. That's from Voltaire. But my version is it's not. They're not really small cells. Only 2/3 of patients have hypercalcemia, and it's not a carcinoma. Apart from that, it's a great name. But I think we basically stuck with the name now in honor of Robert Scully and other people. So it's kind of SCOHT or SCOHT or small cell cancer. The tumor it goes with is actually ATRT, which is a bit of an unusual combo if you think about it, atypical teratoid rhabdoid tumors. But I will just discuss a little bit about the connection between these tumors and SMARCA4 and SWE/SNF complex genes as being sort of the center of it all. We've got a new website, a new program through a registry and a biobank funded by the DoD, and we'll send out the link to you all in the chat. It's not actually fully functioning yet, but if you save it, it will be functioning in a month or so. It's actually something I have learned how very hard it is to get a good website going. It's almost hard as to get in the grant itself. But anyway, so the SCOHT SMARCA4 website will be going, and that's anybody with a SMARCA4 mutation, whether or not they have cancer, anybody with a small cell cancer of the ovary, whether they be tested or not, will be eligible to be entered into our registry. And there's the email there, which is functional, scoht@rimuhc.ca. So where did all this come from? Well, actually, my interest in small cell cancer started with DICER, because DICER causes a type of rare non-epithelial cancer called a SCCOHT stromal tumor, particularly cytolytic cell tumors. And I got interested in the idea that maybe there were other groups of tumors within this category for which there might be familial genes. And I noticed that there were a couple of families reported with small cell cancer of the ovary, which kind of got me interested in that. So over the years, in fact, quite a lot of these non-epithelial tumors have actually been sort of characterized as having germline susceptibility. There's a little list I put together for you. A version of it is published in the Journal of Medical Genetics that you can come read in a review I wrote with Catherine Gowdy and Leora Witkowski, which is about pediatric, even rarer, pediatric non-epithelial ovarian tumors. I think it's been cited about 3 times because it's so rare, and I think people just don't come across this very often. But nevertheless, I think it's quite a nice review covering the major topics. And you'll see here the last column is interesting. The percentage of cases actually caused by a germline mutation is actually very high for SCOHT, about 30% or more. So a high proportion will have a germline variant. Okay, I'll come on to that later. So this is just another little summary made by one of my students. It's a bit unreadable, but the idea is essentially that the colors, so the green is a germline variant, and white is somatic variant, showing these are the genes that basically have been known to be associated with these different types of disorders. So the disorders are here, the genes are here, and then the syndromes are at the bottom. So you can see that that SMARCA4 is responsible for small cell cancer of the ovary, and that syndrome is called rhabdoid tumor predisposition syndrome type 2, which doesn't get used that often in the context of SMARCA4 because it's confusing, because although small cell cancer of the ovary is really a rhabdoid tumor, the name malignant rhabdoid tumor of the ovary hasn't really stuck. So we're back with SCOHT, and then people forget that it's actually part of this syndrome, which I will come on to. So it's sort of undifferentiated tumor, so it's actually very rare. But amongst that class of tumors, it's not. It is actually the major cause. So if you see an undifferentiated tumor in the ovary, it's probably a SCOHT. There's probably around maybe 600 cases now, but it's still very rare, and it's still called a miscellaneous tumor by the WHO. It might be reclassified one of these days. It's hard to diagnose, at least it was until recently, because it didn't have any specific features, and it's extremely aggressive with a 5-year survival of about a third, even in early stage cases. So I mean, it's a really disastrous diagnosis. For which there aren't great treatments. So this is our entry point into the study with these 3 families. As you can see, died at 11, died at 23, died at 16, yolk sac tumor at 15, which may have been a small cell cancer, the ovary. That's one of the differential diagnoses that you could be confused with. And this family here, extraordinary family with twin sisters who both developed small cell cancer, and their daughter. And so how do we approach this? Because a lot of people have died. So we were able to use, this was done some years ago, we were able to use the then new idea of using formalin fixed paraffin embedded tumor to do whole exome sequencing. And that's what we did. We didn't know what gene it was involved. And we basically chose the father and said, well, what does the daughter have the father doesn't have? Here we managed to get DNA from the mum who's alive and the daughter who was alive at the time. And here we again got DNA from the daughter and the dad. And then said, what doesn't she share? And so then we just basically combined the whole lot. These are all the variants found in each family. And we said, okay, so what variant or which genes have variants that are shared by all of them? There were 6 shared by these guys, none shared by those, and 1 in the middle, SMARCA4. So we knew straight away it was the gene because only 1 gene was shared by all of them. So even though we didn't have affected people, we only had unaffected people from some of the families. In terms of pairs, we had 1 affected person, 1 unaffected person. That was enough to give us the idea. And this, we found other families then after that, and they all had this combination. I mean, biallelic in the intro, in the sense it's biallelic in the tumor, a germline truncating mutation, and a somatic truncating mutation, or loss of heterozygosity, which is actually quite common. So loss of the whole chromosome 19 is actually very common in these tumors. And as you can see here, the key finding was Martin Hasselblatt in Germany, who had developed a SMARCA4 antibody, which showed that none of these tumors basically stained for SMARCA4. You can see some little positive here. These are lymphocytes, which are positive because they only have 1 allele that's knocked out. The other one is wild type, and you can see here a complete absence of any staining. So we knew these were non-functional alleles, and then we realized we ought to check, non-familial cases, and it turned out that non-familial cases basically had exactly the same patterns. And basically all cases, pretty much, apart from 1 or 2, which seem to be caused by SMARCB1, are actually caused by SMARCA4. And all cases that only had 1 mutation had LOH on chromosome 19. So it's a very clean story. There's really no doubt this is a monogenic disease, with basically only 1 cause. And since then, we now know in a nice paper from the French group that there's a lot of utility in just staining A4 up front with any unusual ovarian cancer, because if you see it missing, it's probably a small cell cancer, and then they can be referred to genetic testing services. Every patient with a tumor where SMARCA4 is missing should be referred to genetic testing services. There's, to my mind, no doubt about that, no matter if there's family history or not. And it's now been added to most of the panels, in fact, and that will lead me to a related point. The issue of testing people when you don't expect a SMARCA4 mutation. So why is that an issue? Well, if you test a lot of people with a low probability of having a SMARCA4 mutation, then you're going to find variants that you'll have trouble interpreting. And this is obviously a very difficult situation where really, on the one hand, if you do nothing about it, they could get ovarian cancer and die. And if you do the wrong thing, you could end up doing an oophorectomy in a woman who has absolutely no risk. what's interesting, work done by Leora Witkowski, who was the first author of the paper that found the one of the 3 groups or 4 groups that found the gene at the same time. She's now a sort of variant specialist now back at the MUHC in Montreal, and this is one of the things she's focusing on, is trying to work out which variants really are disease causing. And so she noticed that there were no reported cases of SMARCA4 mutations in people who had SMARCA4 related diseases in exons 27 and 30. There were loads of mutations in other exons, but not in those exons. And certain splice-like variants have been seen in multiple persons with SMARCA4 phenotypes. So we wondered, with non-SMARCA4 phenotypes, so we wondered, were these really pathogenic? So just to give you an example, this is a plot using the St. Jude program where you can plot up mutations, and you can see here the focused on the blue and the green cases. Just eyeballing, you can see the blue and the green cases, in other words, unaffected persons or the wrong cancer, are all clustered towards the right-hand end of the picture, pretty much. Whereas all the red ones and the orange ones are more down the other end. Okay, so there's that box there. So what's special about that region? Well, that appears to be where exon 27 and exon 30 map. So here's a case of a woman who came to see us. She actually had she was going to have a prostatectomy no matter what we said, so it didn't actually change things for her very much, but it's an interesting story. She said her grandmother had ovarian cancer at 36, and indeed we found a pathology report which said she did. So couldn't argue with the diagnosis. But she had this variant which was reported as being pathogenic by a number of testing companies. Then we noticed this family with 3 affected persons, none of whom had SMARCA4 related diseases, and the child was getting brain MRIs every 6 months. And obviously the mother was very worried. She's 37, and her grandmother, and so on and so forth. So this is another variant which is also reported as lightly pathogenic. Okay, it's a different variant, but it's in the same region. You can see it's very close, 3951 and 41880. So are they pathogenic? Third case, this is a woman, it is actually published, high-grade serous cancer of the ovary caused by SMARCA4. That's the publication, you can look it up. It's from Florida. I was very skeptical that this was actually really the cause of the cancer. Why? Because the mutation is the same one, 4180, just showing you there. It's the same, exactly the same spot as the woman in Chicago, where we're not sure that that really is pathogenic. Okay, so I asked them to stain the tumor for SMARCA4. They hadn't done that. I asked them to stain it, and the IHC was retained, which is extremely uncommon with a truncating mutation. So I was a bit skeptical. We then actually we got hold of the tumor. We sequenced the tumor, and it showed complete disorder, including loss on 17 and 19. So 19 was lost, but there was no loss of, which is where SMARCA4 is, but there was no loss of protein by IHC. So the other allele must in fact be normal despite this mutation. Otherwise, why would protein still be expressed? Chromosome 17 showed LOH, and that's typical for high-grade serous cancer of the ovary because of a p53 mutation, which she also had. So she had everything that would say this is high-grade serous cancer of the ovary, and nothing to say this was caused by SMARCA4, but just a pathogenic mutation in SMARCA4. So what's going on? We came to the conclusion that not all loss of function variants in SMARCA4 are actually pathogenic. And why did we say that? Because it turns out SMARCA4 has a load of transcripts. 36 exons in the longest transcript, which is the one that most labs use because they like to take the longest transcript, so they won't miss anything. But not all exons are actually present in all transcripts. Look at exon 27 and exon 30 in the boxes. You'll see they're hardly present in any of the transcripts. So those exons, while they are in the longest transcript, are not actually expressed in most people, in most organs. So there are 16 probands we found with particular loss of function variants in exon or intron 30. Nobody has a SMARCA4 phenotype. There are no variants in exon 30, germline or somatic in people who actually have the disease. And in silico tools suggest exon 30 is not highly expressed in the ovary. And there you go there. We actually did some cDNA sequencing of the blood and the ovary from the patient who had an oophorectomy, and you can see that there's no evidence that exon 30 is actually expressed. Exon 29, and there's exon 30. So it doesn't look like exon 30 is expressed in the ovary of a patient who's had a prophylactic oophorectomy. So, I couldn't do much about it. I couldn't, it's very difficult to convince a young woman whose grandmother's died of ovarian cancer that she's not at risk for disease when everyone tells her she is. So, she went and had the surgery. So, well, could you at least please give me the ovary afterwards, as it were? And she did, the surgeon did, and as you can see, exon 30 is not expressed. So it's fairly convincing to my mind this variant does not cause ovarian cancer. In 27, there's only one pathogenic variant. There's only one family with this variant, and it's a non-SCOOHT phenotype. No variants have been seen in SMARCA4 deficient tumors. And exon 27 is only present in 3 transcripts. And it's very low expression of this exon in blood cDNA, and it's not expressed in normal ovary. So again, very unlikely the mutation in this exon would actually be pathogenic. Here's another example of we got hold of another ovary from a patient with an exon 27 mutation, and you can see here exons. You can see at the top exon 26, and then exon 28. So whatever people are classifying these variants as, we think it's not pathogenic. And obviously, correct classification of variants to determine disease risk is pretty important, because more and more people are getting testing done. Bit of ancestry, bit of risk. Why not have a DNA testing party? And then you find you've got a SMARCA4 mutation, and your life gets turned upside down. And I've had a lot of these families. Well, a lot. I've had several families on the phone, in California, all over the place, asking us what to do, because if you get told you've got a pathogenic variant in disease that causes ovarian cancer, you get a bit worried, to put it mildly. What about other family members in the SMARCA4 club, as it were? So there are 3 real kind of professionals in that group. There's the SMARCA4, SMARCB1, ARID 1A. But what's interesting about them is that they're part of the SWE/SNF complex, which is the whole chromatin remodeling group, which all the other family members are shown here. But only really the SWE/SNF actually seem to cause cancer. They have this kind of common structure shown at the top, okay, with the helicase domain, the DNase domain, and so on, and the bromo domain. They have these various domains, which is in common. And what's interesting is that they form this complex, the number of different BAF complexes, which are all SWE/SNF complexes. So it's intensely complicated, which I won't even try to summarize, hard because I couldn't if I tried. But you'd be interested to know, of course, that some of these are associated with different types of diseases, and I'll summarize them in a minute. But there's different. This is neural BAF. This is stem cell. There's different types of BAFs, and it seems that the components are different, and that may have something to do with why certain diseases are caused by certain genes and not others. So these are the syndromes associated with SWE/SNF mutation. As the geneticists amongst you will recognize, some of these are not even cancer related. Okay, SMARCA2. Loss of SMARCA2 actually is important for developing a small cell cancer, but SMARCA2 mutations don't occur in people, it seems, who get cancer, and they're all, of course, it can be different syndrome. ARID1B causes coffin serous. MARC-E causes multiple spinal meningiomas as well as coffin serous. ARID1A, coffin serous. SMARCA4, coffin serous. If they're missense mutations, and truncating mutations seem to cause SCOOHT, as we're discussing. And then SMARCB1, which is the major partner, causes ATRT mainly, but also schwannomas with missenses, meningiomas, and rarely, I think there's 2 cases caused by which cause SCOOHT. So there's a lot to be learned, and we don't know quite why they're so specific, but clearly they all are interrelated. They all have very low mutational burdens, and despite that point, as that Tua was mentioning, pembrolizumab is still probably one of the best drugs to treat relapsed small cell cancer. Nobody knows quite why this is. It may be something to do with to do with R loops, actually, which is an interesting topic that I won't have much time to talk about. But it seems as though that it actually may involve BRCA1 indirectly, that actually BRCA1 may not be fully functional in these people because of the SMARCA4 mutations. So what, as I say, what type of other tumors are seen in SMARCA4? Forget about SMARCB1 for a minute, go back to SMARCA4. Well, the major one is rhabdoid tumors, the ATRTs of the brain. Fortunately, they're terribly rare. Okay, unfortunately, the prognosis is awful. This is actually worse. This is SMARCB1, which is terrible prognosis, germline. This is SMARCA4. So basically, almost everybody dies within 2 years. So they have an awful prognosis. As I say, fortunately, they're very rare. But of course, it's going to be a concern for screening if you identify a SMARCA4 mutation in a woman age 35 who has a daughter or a son who's like 2 or 3. Maybe if they're actually older than 2, you could forget about it because all the cases were diagnosed very, very young. But if they're newborn, and we just had a case recently in Montreal with a newborn who's, positive for SMARCA4, what the hell do you do? Do you offer them MRI, brain scanning every, 6 months? Nobody really knows what to do. There are some SMARCA4 variants that seem to cause both coffin serous and SCOOT, which is interesting. Most of the are missense mutations that cause coffin serous, and most of the stops or truncating mutations cause SCOOT, but some seem to cause both. And we're trying to work out with Leora and Sid Wang, who's a colleague, why is it that certain missenses in SMARCA4 cause coffin serous, where others cause SCOOT. We have one missense in SCOOT, which definitively causes small cell cancer of the ovary and not coffin serous. The protein is retained, but it's in a familial case, so we know it causes the disease. So that's an interesting future project, and obviously anybody has these variants would be very interested to learn more from you about them. And there's also there are rare reports of germline mutations to SMARCA4 causing undifferentiated uterine sarcomas, which I think that's actually one case reported, which of course then begs the question of should you be removing the uterus as well of women who have their ovaries, obviously maybe not in a very young person who might be still able to bear children, but in an older woman, one wonders. But it literally is one case, but you can see here SMARCA4 lost in all the cases, and not much else going on. This is the totality of all the mutations, very little else going on. There's another type of thoracic malignancy caused by SMARCA4 mutations that's different. It seems to be all somatic, and it's amongst smokers, and it's much more disordered genome. So SMARCA4 in different contexts can cause different things. It is also seen in some lung cancers. Just to show you that, make the point is they, to the uninitiated such as me, these things look awfully similar. So this is an ATRT. This is an extracranial rhabdoid tumor. This is a SCOOT. I mean, to me, those tumors, apart from the staining color differences, look pretty much identical. There's no features, right? The bottom one's a little bit different. That's a thoracic sarcoma. And then you've got a gastric undifferentiated carcinoma, which is a little bit different. You can see the normal glands here, and this is the tumor here. And finally, you've got these weird endometrial cancers that sort of become de-differentiated. On the one hand, on the right side, you see it's de-differentiated. On the left side, it's differentiated. So you get this sort of mixture. So the E and F are a little bit different to A, B, C, and D. These tumors tend to be macrosatellite unstable, occur in older women, and tend to be older persons in the case of the gastric cancers. And they tend to be rather different in their profile. And the thoracic sarcomas, as I mentioned, are different again. So the top 3 are very similar, and then the bottom 3 are different in many ways. We've just written a piece about this with this picture in it that'll be coming out soon in the Journal of Pathology. So I think in the interest of time, I probably shouldn't tell you about treatment, but maybe we can talk about it after the next case if we have some time. Yeah, there are some quite interesting developments, and I can go through them. But I think maybe we should just move on, so you can kind of race through these slides, or maybe stop it and move on, and then we'll come on to them later if we have time, just so the next person gets a chance to give their presentation.
Thank you, Will. That's
Yeah.
really great. I do think there will be interest in the treatment piece. What I'm
Right.
wondering is, should we go on to the next case and then talk about all the cases together and then address questions for Will? Because I do think you're going to get a lot of questions, Will.
Sure, I'm happy with that if you want to do that. And I can maybe use the slides to talk about the treatment if it comes up, you know, what's new, what's happening, what trials are going on and so on. But I think case 2, we should look at that case. Yeah.
So this is a case that initially looked pretty straightforward. A 47-year-old male or 46-year-old male diagnosed with a sigmoid adenocarcinoma, had some family history of a peritoneal cancer, a couple colon cancers, and a stomach cancer. IHC was normal for all 4 MMR proteins, but still with a family history, we decided to do a larger panel for him. So we did the INVITE 84 gene multi-cancer panel. And lo and behold, oh, sorry, I have a little bit of a delay. Lo and behold, we found a SMARCA4 mutation. At the time was considered likely pathogenic by INVITE, also an MSH2 VUS. So given then the family history, there really wasn't anything too suspicious. There were no other ovarian cancers. There was the mother's peritoneal cancer. This was a little bit challenging in trying to figure out what does this necessarily mean for the family. So for the proband, is there really any other considerations for him? But also he has a 10-year-old daughter and a 12-year-old son. After some deliberation and some discussion with our pediatric medical oncologist, we did decide to test the daughter, and she ended up being positive as well. So the plan was basically to follow her with abdominal ultrasounds, as has been suggested in a couple of papers, but really it kind of feels like, is there anything else we should be doing for the family? Is there any reason to potentially test the son? Any concerns for him? We have talked about potentially getting testing for his mother with the peritoneal cancer. She hasn't had any genetic testing done at all. Also trying to get his sister tested as well. He has a 44-year-old sister who could certainly be at risk as well. So yeah, my questions was really, what do we do for follow-up for potentially affected family members? Interestingly, his daughter has had some abdominal and some pelvic and retroperitoneal ultrasound. She was born with a single kidney and doubling of the uterus. So it was actually a little bit fortunate that she has already had some ultrasounds that haven't indicated anything concerning on the ovaries. But is there anything more we should be doing?
So thank you. This is a great case. Maybe we can stop the slides and have panelists come in to kind of have a discussion with Will.
Sure. Well, this looks like it's it's one of these exon 27 variants that doesn't actually cause cancer. Is my first response. If you go back to the variant, I think it's 3952. You said.
Yes, 3952.
Yeah. So if I just on my other screen, I will just check. Just wait 1 second. Yeah, I mean that's exactly the we had 3951 plus 2 T to C, right? That's not pathogenic according to us, and this is 3952 minus 2. So basically, my guess is that this doesn't cause small cell cancer of the ovary, and the child isn't at risk of anything, you could probably forget about it. But obviously that's a bit of a bold statement. So I would suggest that you, first of all, I would stain the colon cancer, right? Because if it really caused it, then there should be loss of the protein. For SMARCA4, we could do that if you can't get that done locally. Although I think the antibody is fairly widely available now. It wasn't at the time, but it is now. So that's something you could get done. The other thing would be to, if you can get some of the colon tumor to us, or lymphoblastoids or RNA or LCLs from the patient with the mutation, we could determine whether or not, like we did for the other case on using cDNA, we could determine whether exon 27 is actually present in the blood of this patient. Now, obviously, finding it's not present in the blood isn't the same thing as finding it's not present in the ovary. But if we had the colon tissue plus the blood, and we could prove that exon 27 wasn't actually expressed in either the colon or the blood, I think the family might be convinced that the variant doesn't actually do anything, and it's just an unfortunate sort of twist of SMARCA4 structure that these variants are getting called pathogenic. So we'd be very happy to work with you on this case if you want us to try and help you work it up. It may already be in our database because Leora has basically written to all the testing companies and has got data from Genomics England, as well as Invitee, Ambry, GeneDx, and various other university labs. So we do have a lot of data now, and maternity leave notwithstanding, we should have some better data on this for the public to look at. As Talia was saying in the chat, I mean, some of the companies have already kind of recognized that some of these variants may not be pathogenic, but it may take a bit of a push, a publication from us to actually really convince everybody. So I think let's wait and see. Yeah, RNA testing would be helpful, actually. RNA testing, which is now offered by Ambry and Invitee, I'm reading the chat as I'm talking, would be helpful. That's what we're going to do, essentially. But if you can get it done commercially, then great. As long as the data gets shared with us or other people so we can actually report this stuff out to other people, it doesn't stay, as we tend to do. We all have loads of data sitting in our labs and in our notebooks that we don't have the time to share, but sometimes it would be great if we could. So yeah, it'd be nice to know what you found if you do send it to a commercial lab to get RNA done. That would probably help to answer it, yeah. ClinGen doesn't have a SMARCA4 panel. We've talked about trying to create one. There's been a bit of resistance, I think, because, there's already, it's funny, this sort of politics of SMART-B1 is like ATRT, that's pediatrics, and this is sort of SMARCA4, which is different. And also, actually, it turns out that, there's not much money to create these panels. And I'm on the DICER VSAP, and it's, Leora is the vice chair with Doug Stewart, and it's not a trivial amount of work, actually. They have a person working with them, not full time, but largely is devoted to this process, organizing the calls, calling the variants. I'd like to do it, and we'd be in a good position to help, but it's not necessarily going to be something that we could do tomorrow.
So, Will, you've seen on the chat, there's a lot of interest in your registry. I also wanted to introduce you to Dr. Lauren Prescott, who the original patient was Dr. Prescott's with ovarian cancer. And she just, if you noticed in the chat, has another patient with SMARCA4. So I think we have some patients here that could be enrolled.
Yeah, well, that's great. We'd love to. I think we have about 20 or 30 people so far enrolled. It obviously takes some time. Retrospectively, we're speaking to the Maren Peterson, who started the small cell, sort of foundation when her daughter died of small cell cancer. And I've been talking to Maren for some years, and she's made available some of the connections that she's made, and also Katie Oppo, the Katie Oppo Research Fund in New York. That's also, we've been speaking, and also to Eva Peel in the UK. So there's a number of groups that have got together. So the idea is to make this sort of like a registry for everybody, and to make it pretty open access, and to make data available. And PDXs are really what we're interested in from a research point of view. So the grant that we got from the DoD was to establish the registry, but more especially to establish PDXs, because without those, it's very difficult to test new therapies. So we got one. It's extraordinary at McGill just like a few weeks ago, just out of the blue. They count every 5 years or so at each hospital, usually, something like that. And so that's actually gone. The PDX is probably going to take, I think, because it obviously was 15 minutes from the operating room to the animals. But if you know that you're going to operate on a patient, it's usually reoperations, of course. You don't know they have it usually until you've gone in and you think, oh my God, this isn't an ovarian cyst. This is in a 25-year-old, who would suspect that, right? It's not common unless the calcium's elevated. You're not going to suspect it out of the blue, or they have a family history, which is very uncommon. So often it's reoperations. In our case, we knew about it before, they went back in because the first operation was like a cyst removal, and they realized, oh my God, it's small cell cancer. We've got to go back and then do a proper gynecological cancer operation. And then we got the material, which unfortunately was plentiful. So, disastrous situation. She's like 23, she's got 4 children, just absolutely awful. So we're trying to get treatments going. So the main message from the point of view that would help me and would help the community would be if anyone could contact us in advance when they know they're going to operate on a patient who has small cell cancer or is suspected to have it. And then we can send you the protocols, which will be one day on the website available for everybody. And then the idea is that we're trying to come to an agreement with the JAX lab, the Jackson laboratories. It's a bit tricky from an ethical point of view because of trans country issues and all sorts of ethicals, but is to give them to the Jackson labs, so that we don't want to keep them for ourselves. We want to give them to them, and then you can buy them from JAX. So JAX will keep them for minimal cost, and then because they're the premier lab for PDXs, I think, in the world. And then the idea is that you would be able on the web to go and choose, oh, I want to work on that PDX, and then you can go and get it without having to pay for it. I mean, it's a minimal charge. I think it's like $1,000 or something. So the idea is to make them more widely available. So that's our commitment, So in terms of the data, the idea would be that we would be able to look at things like penetrance, which is a question that two are raised. And of course, it's the question I get asked probably the most is, what is the risk? And the truth is, I don't know what the risk is. Because you probably have to kick out cases like Andrew's, where the penetrance looks to be really low. Well, yeah, because probably the variant doesn't actually cause cancer. So if you had a variant that you knew caused cancer, what is the risk in those, or could cause cancer? What is the risk in those people? That's a great question. It's going to be lower than we think, because it always is, right? The penetrance always goes down over time because of the winner's curse. So I think it will be something like 30% lifetime risk, something like that, but the trouble is you see cases reported in neonates, you see cases reported in women age 50. The fascinating thing is, as you probably know, those of you who've read a bit about it, is it doesn't really occur in women after the age of about 55, which makes one wonder whether the cell of origin actually might be a germ cell that sort of has died out, as it were, because we don't know where these things come from. They don't appear to be carcinomas, epithelial. They're probably not stromal tumors. So the only thing that's left really would be the germ cell, but we haven't been able to prove that. But my guess is that's probably what they are. But that does mean that, women, the ascertainment is a bit tricky, because obviously, how you ascertain the family will determine what your risk will be. If you ascertain a family because they have 2 cases, then lo and behold, the penetrance is really high. But we know from testing with Invitee and Ambry and all sorts of companies now that it's actually, many people don't actually have small cell cancer who have these variants. So that's the point of the registry, to follow these people up, for the next 10 years and see what happens to their family members and test as many people as possible and so on and so forth. So I hope that will be of interest to people in the future.
Now, Will, what is the proportion that are inherited versus spontaneous mutation that first happens? Do you have any sense of that at all?
Yeah, that's a good question. When we first published the paper, we said it was 45%. I think everyone else thought, oh, that's way too high. All the other groups who published said it was much lower. I mean, it's interesting. I started from a genetics point of view. So obviously I searched for the gene by starting with families, because that's what I was trained to do. And I kind of always thought that that's the way to try and find genes that cause familial cancer, is to look at families with cancer in them. So that's the way we kind of did it. But obviously there may have been a bias, but I was surprised, in fact, that it was that high. But I think that's kind of holding up. I mean, basically all cases that we found under 15 were caused by germline variants, all cases. That was the first thing. As you get older, the proportion goes down. But the mean age of diagnosis is about 25 years old. And I think probably most of the cases under 25 are hereditary, and it's probably close to 40%. It may be a bit of an overestimate, but that's my point, is anybody who has a small cell cancer needs to be tested for the germline. I mean, needs to be offered, usual caveats, needs to be offered testing, because it is a preventable cancer. Now, obviously, the horrendous dilemmas of what to do about a case, a woman, we had a case recently in Alberta of a woman who had, so the husband is surviving, the wife died in her 30s or early 40s of small cell cancer. They tested the daughter, she's like 8 or something, and they wanted to do an oophorectomy, so I was obviously rather against this for all sorts of reasons, but the dad was sort of adamant. I think they ended up going to court and stuff, so I can't remember exactly what actually happened in that case, but I suspect they ended up doing the surgery, so which I obviously was not pro the idea of doing surgery, and somebody who hasn't even gone through puberty. My view is they need to go through puberty at the minimum, and hopefully you can hang on till the early 20s. Even then, it's obviously very, very young, but at least it's a woman then who's fully mature, and the prospects of having children through other means are not lost on that person. So it seems to me that's one of the real issues, which relates to penetrance, but it's never going to be really, really high in children. It's never going to be like 50% or something like that. But, as we all know, the perception of risk is much more important than the actual risk. And if your wife died of small cell cancer after like 3 months of sort of from being well to dying, then you're not going to be very receptive to, well, let's wait and see, and ultrasounds don't really work, so we can't do anything, come back when you're 18. I mean, that's not going to cut it for most families, just realistically. So although we don't recommend ultrasounds, and Mark and I have written about this, suggesting that it doesn't really, there's no suggestion it actually works, you may be forced to do something like that, if only just to prevent them from doing surgery. So better to do something that isn't perfect than to do something that's definitely the wrong. I think 8-year-old having an oophorectomy is the wrong thing to do when we don't have a handle on penetrance, but we think it certainly is going to be pretty low before 15, something like that.
So the other question, I mean, with Lauren having 2 patients, I think we'd be very interested in hearing about, well, what's coming down the pike with treatments.
Yeah, okay. Well, I think the Pembro story is certainly very exciting. There's a trial now in France run by Patricia Potier, which I strongly encourage anybody to talk to them about. Obviously, it's only available in France, so it's a bit limiting if you live in Tennessee. But nevertheless, it's worth talking to them about that trial, and maybe there'll be a chance to open a branch of it in the US. That's Pembro for relapsed small cell cancer as a single agent, I believe. Susie Banerjee's involved, so you could talk to her about it if you're an oncologist. The other thing is Palbo. So Palbo plus Pembro, or one of those immune checkpoint inhibitors plus a CDK4/6 inhibitor. It doesn't have to be. I'm just calling it Palbo with Pembro because it's easy to remember, but it could be one of the other family members. And that's been used in a recent paper in the JCO Precision Oncology, where the patient actually is, I believe she's still alive. I think there's 2 patients now on this combination. And Palbo may actually have immunostimulatory effects, irrespective of its cancer effect. So we're hoping that palbociclib may have a good effect with Pembro. So that's something to think about if you've got a patient who's relapsed after standard therapy, which would be probably, high dose therapy with 6 drugs probably, and maybe a stem cell transplant in some cases as well. So that's one thing. The other thing is I mentioned the R-loop story. So that's the work done by Sid Huang, which isn't published, but Sid has got strong evidence that there may be an R-loop connection, and that then opens the question of PARP inhibitors, so which wasn't something that most people had thought about. So there's a number of interesting things happening in the field, and I think the reason why the PDXs and why we went down that road is so important is because without those models, you can't really test out the drugs. We organoids and so on are terribly useful. So we do hope that people will sort of rally to the cause, as it were, and try to get these PDXs established. They'll be established at McGill by Morag Park's team, who's very experienced in doing this stuff, not by me, who has no experience, but I know people who have experience. The question, I think there's one question about SMARCA4. I think there's like 2 cases. I think David Huntsman actually has published one case of a SMARCA4 small cell cancer, and there's another case I heard about listening in on a molecular tumor board from BC, another case, funnily enough. I don't know what these really are. I mean, maybe they're just sort of, extracranial rhabdoid tumors occurring in the ovary, and so maybe they're kind of the same thing, but I don't know if they're really different. I think they're probably very much the same, to be honest. And my guess is it's just one or the other, and for some completely unknown reason, SMARCA4 tends to not, cause ovarian cancer, but cause brain tumors, and it's sort of 99% to 1%, if you like. SMARCA4 causing ATRTs, 1% causing SCOOT, and then it's the other way around for SMARCA4, 99% causing SCOOT and 1% causing ATRT. So it's like an inverted thing. And that's probably some tissue specificity of maybe the BAF components. I mean, God, I don't really know. And I don't know how I'm going to find that out. But I think basically SMARCA4 patients are going to be surveyed by MRI because of the real risk of extracranial rhabdoid tumors. If they survive or haven't yet had a brain tumor, then they would definitely get screening that would include probably MRI, which would go down to the pelvis. So they would pick these things up, what one hopes. But I don't think there's much we know about their outcome. It's probably similar to SMARCA4.
Now, can you tell us a little bit more about your registry? Because I'm seeing a lot of interest in the chat with the registry. So, once your website is up, are you going to have online recruitment? Just tell us the nuts and bolts, and I think a lot of people will be interested.
Well, the registry is up and running now, so you can email SCOOHT@rimuhc.ca or myself, and Melissa Taxjian is the one who's running it. Melissa is our sort of, she's basically running the show. So essentially it involves help from you, because we'd like to know what treatment people had. So we do need MD input. It's a patient-led thing, okay? So the patient has to register first and has to give us permission to access data so we can write to the hospital and get path reports and so on. But we're going to need help from the MDs where possible to fill in, chemotherapy details. We really, it's a fairly, I hope, long but not daunting questionnaire, asking questions about what treatment you had. We spent a long time trying to develop this thing to pick everything up without being too overwhelming on, what questions to include. But essentially that will allow us to, it's like an online click type thing, with, is this your first, have you recurred? What treatment did you have? All that kind of stuff. So, if you register, you'll be able to try it out yourself, and by all means connect with Melissa and she can help you. But if there's any patients you have who you think might be eligible, then please let us know. To be honest, even deceased patients are interesting, because unfortunately this is what we're dealing with. It's the mums and the dads who are helping us with some cases, because they've died and they want to help, and so we're getting data retrospectively. The idea is to collect pathology blocks, blood samples from living people, pathology blocks, and PDXs if it's possible from current cases. So with the goal of building a complete registry that then biobank and registry, such that the samples will be made available to interested parties. Again, make a TMA, for example, and then share the TMA with people for the research community, because it's not my goal to hoard this stuff. I mean, it doesn't seem much point. It's incredibly rare anyway. It doesn't really help the patients very much. Obviously, we want to use it for our own reasons, for our own research, but we want to share it with others. And I think if people can buy into that, then I think if we get 150 cases or something, over the course of a couple of years, I think then we could start to make inroads into the questions that people really want to know, like what is the penetrance and what are the phenotypes? Is neuroblastoma, for example, part of small cell cancer, part of SMARCA4? That's a question that's come up quite a bit with us recently. We're seeing a couple of cases of neuroblastoma. It looks like it could be real, although very rare. What about, the cases that you just discussed today? Is that because the variants don't actually cause colon cancer, or is it that it can occasionally cause, can cause these cancers, but we just don't see it very often? And certainly, if you look at the literature, there are reports of SMARCA4, mutated colon cancers, but they're probably a bit like SCOOHT, but occurring in the colon. They're not really, classical adenocarcinomas, which is what I think Andrea's case was all about.
So you are interested in the ones that may not, that are coded as pathogenic, but really may not be pathogenic.
We're very interested, yeah. So the reason the registry is SMARCA4 and SCOOHT. So it's anybody with a SMARCA4 variant that is likely pathogenic or pathogenic, right? And anybody with a small cell cancer. And if they have both, then obviously that's great. But some people don't, and we don't want to sort of step on the toes of the cough and cirrus people, so we're going to share data with them. But obviously we can't really understand small cell cancer without understanding cough and cirrus a little bit, because why is it that missense variants cause a completely different syndrome that doesn't even include tumors, and yet truncating mutations cause this devastating disease that those of you oncologists probably dread to hear about and dread to see.
Perfect. Well, thank you, Will. This was a really, really great case conference. We really appreciate your participation. We'll certainly be sending you SMARCA4 patients from our site wherever possible. Right. And I think there's a lot of interest across our network. And we'll certainly, once you have the link, the website available, we can e-blast it to all of our partners as well. So just let us know.
That'd be great. Yeah. It's frustratingly not quite ready yet, but I was hoping to have it ready for this meeting. I was pushing everyone a bit, but sometimes you can't push too hard, so it's not quite ready, but it will be ready soon.
So that's perfect. And in the meantime, we will send out an email after the call. We often will send out something that gives the contact information, just so everyone has it. So if you have any sort of flyer or anything, just give it to us and we can certainly blast that as well. But with that, our next case conference is November 11th. It's focused on inherited pediatric cancers. And our guest expert will be Dan Benedetti, who's a pediatric oncologist at Vanderbilt. And then we have line up the dates scheduled for next year as well, and we're just in the process of finalizing guest experts. So with that,
next slide. Oh. Yeah, let me briefly talk about this, and I'll include it in the email as well. This is a monthly journal roundup put together by the Cancer Genetics Group and the Genturis out of the UK. So these are genetic counselors that compile journal articles, and then they share them with whoever joins the monthly journal roundup. So if you want to join this, the topics are, bigger picture, translational science, in the clinic, counseling and ethics. You can either, just receive the monthly roundup, or you can contribute by sharing a summary. And then here's just a list of September's issue to give you an idea of what they typically is included. So if you have any questions, or if you want to join, I'm going to put Izzy's contact info in the chat, so feel free to reach out to her. But again, I'll include it in the follow-up email. All right. Well, thanks everyone. Thank you so much, Dr. Foulkes.
Pleasure.
We'll see you all next month.
See you too. Thanks, Brenda.
Bye. Thank you. Bye-bye.
Take care, everybody.